This conference will now be recorded.
Okay, so welcome to chapter 27, EMT book, chest and abdominal trauma. It's about 45 minutes since Army lost to Navy. It's not a good night. Anyways, so we're going to talk about chest and belly trauma. This chapter, or the EMT book, puts both of these chapters together, both these topics together in one chapter. The EMT book breaks it out separately. I don't feel that either one of them is superior by any means. I think that this book, with the two topics together, does some things really well, and I think the other one, breaking it out, does a few things really well also. So here we go. Let's talk about chest injuries to start with. So blunt trauma, we worry about ribs, the sternum, and rib cartilages, okay? Hang on a second, move this over. So costal cartilages, which are ribs. So we can take a shot to the ribs with a steering wheel, handlebars, a baseball bat, and have blunt trauma. We can also have compression where we get squeezed between things. And it's a compression. Think of a chest compression in your cardiac arrest patient. We are pushing down, creating a high amount of positive pressure and forcing air out through the airways, out of the oral and nasals into the environment. And we're also pushing blood out to the body. When we let off, we create negative pressure, which pulls air and blood back in. So picture the compression from hell. You know, you get crushed between a car and a wall, a loading truck or a ramp truck and a loading ramp, okay? Causes that, excuse me, significant sudden increase in pressure, the compression from hell. So we'll talk about those. Penetrating objects, it doesn't matter what it is, anything can become a penetrating object, okay? Pens, pencils, certainly weapons like arrows, bullets, right? Knives, glass. And besides damaging those internal organs, if we create a hole in that outside structure, we now create an avenue for air to leak in. Because remember, air is like water and like electricity. It will take the path of least resistance. So if you have a hole in your chest, when you create negative pressure inhaling, instead of all of the air coming in through your mouth and nose, some of it will squeak in through that hole and it will separate out that pleural space, giving us a pneumothorax. And that is going to screw with our ability to have ventilation. This is a great example, a great drawing or diagram of what we call a flail segment. So you've got 1, 2, 3, 4, 5 ribs that are broken. 4 of them are broken in 2 or more places. So if you think about taking a breath in, right, you contract your intercostal muscles and you contract your diaphragm, and the diaphragm goes down and the intercostal muscles come up and out, and we create negative pressure. This segment of chest wall, it's still intact as far as muscles go. The muscles and the cartilage and all that are all intact, but this section of chest wall will now move opposite. So you take a breath in, create negative pressure, this flail segment will actually get sucked in a little bit. And when you exhale, creating positive pressure, it will push it out. So you don't have an intact chest wall that moves together. So your ventilation ventilatory effort gets diminished significantly that way. 2 or more ribs in 2 or more places makes it a flail. Another great just example of that. We inhale, that segment gets pulled in. We exhale, it gets pushed out. Best way to take care of that, put your hand right over it. It won't prevent it from being sucked in on inspiration, but it will keep it in place when they exhale. The other way you can splint this is from internally. And what do I mean by that? Bag valve mask, okay? Ventilating them. You will force positive pressure, force air into the lungs and the alveoli, which might push that flail segment out a little bit. And they're still not going to exhale as adequately as they would normally, but you will splint that on inspiration, and in a lot of cases, you may very well save them. So 2 or more ribs, that paradoxical motion term is describing that section of rib wall that's moving opposite of the other one, of the rest of it. So think mechanism of injury. You know, what happened? They fell, they were on a ladder, they fell, landed on a rock. They were on a ladder, they fell, landed on their elbow against their side, right? So they tucked their arms in, or their arm was tucked in, and they landed with their elbow digging into their chest and the ground. Baseball bat, horses, you know, getting kicked, whatnot. So mechanism of injury. What is their ventilator? What's their ABCs, right? As you walk up, what do I see, hear, and smell? They look like they're short of breath. They look like they're hypoxic. You know, they're pale, they're cool, they're diaphoretic. They can't speak a full sentence. Pain, a lot of times, certainly makes sense. They got a bunch of broken ribs. Broken ribs by themselves will make people take a shallower breath because it hurts less. So now we've got this paradoxical motion and a bunch of pain. And these people are hypoventilating, right? They may be breathing 25 times a minute, but their tidal volume is so low that they're not bringing in the amount of oxygen they need in a minute volume to be able to maintain perfusion. Chest wall muscle contraction, just like, you know, we talk about femur fractures, you can certainly have some spasm of that chest wall when you have rib fractures, and that's going to hurt a lot more too. So our ABCs, D's, E's, environmental, expose, right? Flail segments, you got a little bit of oxygen. Trauma is not cardiac care. I know it kind of sounds silly to say it that way, but when we talk coronary artery disease, we talk strokes. The studies support the fact that if their O2 saturations are 95 and above, and they're not shocky, and they're not short of breath, they don't need oxygen. Trauma patients need oxygen, okay? So you've got flail segment, throw them on a non-rebreather. If they're not breathing adequately, ventilate them, right? 12 times a minute, 15 liters. As far as non-invasive positive pressure ventilations, this would be things like CPAP, BiPAP. That's contraindicated in chest injuries because you're pressurizing that. I mean, you are with a BVM also, but CPAP leaves more pressure behind at the end, which a BVM doesn't, right? End pressure. So not a good idea. Watch them carefully. Watch their rate and depth. As far as open injuries, difficult to tell what is injured from the entrance wound. Here's the other thing. It's super hard to tell what's an entrance wound and what's an exit wound. And quite frankly, I don't give a damn. I got a hole here, I got a hole there. I don't care which was which. I want to line the 2 holes up if I've got 2 holes. I want to line them up and visually, you know, put an arrow between those 2 holes. Don't do it figuratively, right? And figure out what's between them. The problem is with that some of these rounds, ammunition that might be used in some of our modern weapons tumble. So you might have a hole, let's say on the right side bottom rib, mid axillary line, right? So the middle of their armpit down at their 12th rib, and it hits the rib and tumbles. It shoots off in a different direction completely. It might end up down in the pelvis. It might end up up in the left shoulder, and you've only got that one hole. You don't really know, okay? Any open chest wound, you've got to seal it. So a piece of plastic on it, we'll see a diagram in a minute of that. The other thing you can do is a commercial chest seal. Again, along the lines of KED and Band-Aid and Q-tips, Asherman chest seal was the original. So people tend to just call all of these things Ashermans, but it's a round rubberized type dressing that goes on. It seals all the way around it, but in the middle it's got this thing that looks kind of like a finger, a glove, a finger glove, finger from a rubber glove stuck out of the middle of it with a little hole in the end. So if pressure builds up, it can be pushed out through that, kind of quacks like a duck call, and then when they take a breath in, it collapses to prevent any more air from coming in. So we get open air in the open wounds, which allow air into the chest. Remember, we have pleura. In the belly, we have peritoneum. In the chest wall, we have linings called pleura. Again, a visceral pleura around the lungs, around the organ itself, and a parietal, which lines the chest wall. In between these two linings, we have a very little bit of pleural fluid, which allows those linings to glide seamlessly, frictionless, and painlessly. And it also provides surface tension. So what I mean by that is that when the rib cage expands up and out, that parietal pleura moves with it, and the fluid that's in there creates a surface tension with the visceral pleura, and that pulls that up and out also, which then expands the lungs themselves. So if you start to put a little air in that space, you no longer have that tension, that surface tension, and you actually have that lung start to collapse or drop, whatever terminology you may have heard for it. The lung isn't expanding anymore, and at some point, if that gets to be too much air in there, it can start to shift the heart and the other lung. So open chest wounds get called sucking chest wounds because they can suck air in them, in through them. I've read the description that that hole needs to be 5/8 the diameter of the size of their trachea for it to do that. So it's a fairly decent size hole, but seal all holes to be safe, okay? And as far as the term sucking chest wound, if it's a big hole and you are moving quite a bit of air through it, yes, you will hear that kind of sucking sound, wet, raspy sucking sound. But if it's a smaller hole, it's not moving a lot of air. I mean, I've done a bunch of open chest wounds and I've only heard that sucking sound a few times. So look for it, listen for it, but just because you don't hear it doesn't mean they don't have an open wound somewheres. So ABCs, right? A hole in the chest is not an airway problem. It is a breathing problem. So make sure the airway's open, and then take your gloved hand and put it right over that hole. First thing, just boom, right over the hole. Then have somebody get this occlusive dressing, occlusive being a seal, whether it be a commercial like the Asherman or whether it be one that we make. And again, we'll see a diagram of that in a minute. High flow oxygen, right? Non-rebreather, 15 liters a minute if you don't have to bag them. Chest wounds, you have to assume there's blood vessels involved. Remember that under each rib, there is a vein, a nerve, and an artery that runs along the lower edge of each rib. So likelihood is you're going to hit one of those. Also, let's face it, inside the chest, there's a ton of vasculature because of the lungs, right? For that whole cellular respiration thing, alveolar respiration thing, sorry, and heart, big vessels, right? So you have to assume there's some bleeding. Care for shock, head for a trauma center. ALS. ALS is a great idea, but don't wait for them. Don't wait. Well, they're coming from the opposite direction. They'll be here in 15 minutes. You might be at the trauma center in 20. They need that trauma center more than they need a paramedic. But why a paramedic? All right, so let's say you have a hole in the chest. If that hole clots up, which a lot of times it will, you know, you've got blood in it, it clumps, it creates a clot, and it seals that hole. Hey, that's great, except they're still leaking air in their chest. That pneumothorax, the air between those two linings, gets worse and pushes the heart over, pushes the big vessels over, pushes the lung over. They become extremely short of breath. Their blood pressure plummets and they're dying. Paramedics can take a needle, stick a needle in the chest to make that to make a smaller hole to allow some of that air out. Now, in the Army, the military, they're teaching enlisted and officers, but non-medical people, that if that hole clots off like that and they become acutely short of breath, they become hypotensive, take your finger, stuff it in the hole, and push that clot out, open it back up again, and it will get better. And it absolutely will. I brought that up to our med control board to include that in our protocols, and they lost their minds. Oh my God, no, that's horrible. Oh, we just get called for a paramedic to stick a needle in their chest. Needle decompression is what it's called. I was like, we don't have medics every place, right? There are a lot of times we don't have medics available. They wouldn't do it. If this was my chest or my loved one and that hole clotted and they started to die, I would stuff my finger in it and open that clot back up. Don't get yourself in trouble on an ambulance. It's not in our scope of practice. But if it's you or a loved one, the hell with them. So what we're going to do is we're going to take a piece of plastic if we're making one. So it could be a wrapping off of a dressing. It could be a wrapper from around an IV bag. And we're going to make it roughly square and bigger than the hole. And we're going to tape it on basically 3 sides or 4 sides and leave just a corner. Either way works. And I'll explain that in a minute. A little better, you'll be able to see it better. So as they inhale, we create that negative pressure. That dressing, that plastic gets sucked into the hole and seals it. When they exhale and build positive pressure, it pushes it away and air can actually come out through that hole. So what I do initially too, I mean, right, boom, I put my hand over it. While somebody's getting me a seal, I tell them to take a deep breath and I want them to cough really hard. And when they cough, I'll take my hand away and then put it right back on before they inhale. Same thing with that dressing. Once that's in place, I'll have them cough a few times. And what that does is forces a little bit more of that air out from that space. So this is what we were talking about. You can see that it's got one corner open. So as if air is still building up in there, they can cough, grunt, strain, whatever, and get some of that air to escape. But you can see how the holes line up, right? The holes line up through either through the rib by the looks of it, or intercostal muscle down through the different linings right into the lung tissue itself. So they inhale, it gets sucked in, they can't pull any more air into it. They exhale, some of that air squeaks out and makes them feel better. So think about this. ABCs, what's going to kill them in the next 1 to 2 minutes. So does the chest injury they have need to be treated right now, or is it something that can wait for our rapid trauma exam? Well, if it's affecting breathing, you got to fix it right now. Does their injury require an occlusive dressing? If there is a hole at all, it could be a laceration, it could be a stabbing, a cutting wound, it could certainly be deep enough. So you find any sort of opening in the skin in the chest, throw an occlusive dressing on it. Does this injury require transport to a trauma center? If you're looking at a slashing type knife wound, and you're like, I don't think it's all the way through the rib muscle, right? I don't hear any bubbling. I don't see any bubbling. Excuse me. They're not short of breath. Their lung sounds are good. Their vital signs are good. I think he's just going to get some stitches. Then yes, he could probably go to the local ER. But if you look at it for any reason and go, "Ooh, boy, I don't know," then he goes to a trauma center. Now, pneumothorax and pneumothorax. I'm not quite sure what this slide means by that. Pneumo. Okay, so typo. So pneumothorax, I think it's supposed to say tension pneumothorax. So pneumothorax is air within that cavity. We find some of these by accident in ERs, like somebody comes in, they've had a cough and a cold, they've been coughing for a couple of days, they're not short of breath, their vitals are great, their lung sounds are good. Well, let's take a chest x-ray to make sure there's no pneumonia, and oh, there's a little bit of a pneumo there. And they send them home with it, and they follow up and just have them come in if they're short of breath. Because most of those little ones, like, kind of think about the moon when it's a sliver at its lowest point. You know, the very top part of the lung may have a little bit of air in it, and that little bit of air looks like the sliver of a moon. The body will fix that most of the time. A tension pneumothorax is when enough pressure builds up inside of those two linings that it starts to shift. So the lungs collapsing on that side. So we've lost that alveolar space to ventilation. And now we're starting to push against the other lung, which will then start to lose alveolar space for ventilation, become acutely short of breath. The other thing that building this pressure up does is it does not allow the heart to expand and contract effectively. Blood pressure can drop. Also, if let's say this tension pneumo is on the right side and it's pushing the heart to the left, remember the aorta comes up off the top of the heart and curves around to the left. You could actually kind of hinge that, kind of like closing a door. You could hinge that vessel and actually like close it off like closing a door would. Think about it as like closing a door. And so therefore you have an obstructive shock, right? You can't deliver, right? It's obstructing blood flow. So obstructive shock, boom, blood pressure plummets. Or you could end up actually putting enough pressure on the vena cava that blood can't return to the heart. Again, an obstructive event, okay? Blood in the thorax, blood in the chest, hemothorax, so pneumo, air in the thorax, hemo, blood in the thorax, works the same way. You can have a little bit of blood, not a big deal, but you can have a lot of blood shifting everything, tension hemo, or you can have both blood and air. So hemo, pneumothorax. Traumatic asphyxia is that injury I described as the chest compression from hell. There's a good picture of a guy here in a little bit that suffered that. Cardiac tamponade, excuse me, around the heart, there's a pericardial lining. That pericardial lining is a very tough, fibrous material. And the heart can only expand so much before it contracts. So if you get blood between the muscle of the heart and that pericardial lining, you'll start to take up space. The heart cannot beat as effectively. The more fluid you get into that space, the less effective the heart becomes. Cardiogenic shock. Okay? Now, it could be blood from a traumatic injury, or it could be pus from an infection. Okay? Damage your aorta, whether it be a shearing event. So when your aorta comes up out of your heart, it forms that circle kind of at the top before it starts to come back down through the chest. there's a ligamental attachment point that keeps it in place. Ligamentous arteriosum, and that's a rigid, a ligament is a lot tougher material than a blood vessel is. So if that heart goes swinging too hard, too violently because of your traumatic event, you can actually tear the aorta where that ligament attaches, and then you're dead, right? I mean, you dissect, okay? You dissect an aneurysm, blow an aneurysm, or you tear your aorta. If you're not already cut open on the OR table, you're pretty much dead man walking. Okay. So I've described this. We'll go through it again though. Make sure that you guys understand this. Pneumothorax, air enters the chest cavity. Now, air can enter from the outside because we have a hole on the outside from whatever. There was a nail in the grass and the lawnmower kicked it out. Okay. I mean, stupid stuff, but it's just as deadly. Or you can have a hole in the lung inside, letting air out through. Okay. So air enters chest cavity, possibly causing a collapse of the lung. Tension pneumo, that pressure builds up to the point where it can't escape and it continues to build and it starts to shift everything over. So this is a good little diagram about what I mean with air entering from the outside. Puncture in the chest wall, you can see that lung is starting to collapse. This is not a tension pneumo yet, right? Everything is still in the center. The trachea comes down, it's still in the middle. It's not starting to deviate left or right. Are they short of breath? Yeah, maybe. But I've seen some fairly large pneumos where, they were short of breath when they walked, for example, dyspnea on exertion. It depends on their underlying health, right? You're a 70-year-old COPDer, you cough real hard, you pop a weak spot in your lung called a bleb, and you now start to leak air out of that into the pleural space, you are probably going to become short of breath fairly quickly compared to a 19-year-old who runs and pops a lung coughing because he's got bronchitis. Now, lung sounds. Diminished would be the best description. I've taken care of a couple of horrific tension pneumos, and when I listened to lung sounds, I was like, ooh, I hear lung sounds on both sides. But one is a lot stronger and a lot louder, and the other one is diminished. And the reason for that is, although the lung is collapsed and not there and not expanding with air, you're hearing the sounds being transmitted from the good lung. So you're hearing me speak right now because sound waves travel. My vocal cords and my tongue and my throat and my mouth and my lungs are forming sounds that are being picked up by the computer, and then the computer is spitting it out into the air and you're hearing it. A lung that's inflated on the right side in a lot of cases will transmit noise across that empty space on the left, and you will hear diminished lung sounds. So good mechanism of injury, or bad mechanism, I guess, how you look at it, right? So an appropriate mechanism of injury, a little anxious maybe a little short of breath, and maybe a little diminished lung sounds, that's a pneumothorax. No doubt they go to a trauma center. Again, with a bleeding event, blood builds up, hemothorax, blood and air, hemopneumo. Now, if you said to me it was some sort of sick reality show, Kevin, you have to have a hemothorax or you have to have a pneumothorax. You can't get out of it. I would take the pneumo. Holes in lung tissue in some cases will seal. Bleeding vessels in your chest are never good, okay? A hemothorax, a lot of times, a chest tube, right? A tube gets put into the chest, drains the air out, lets the lung fully inflate. The body will heal that by itself over time. You can bleed to death pretty quick through a vessel in your chest. So on the left, pneumothorax, got air squeaking out from a wound or a weak spot in the lung. Hemothorax, we've got damage. Maybe it's a artery that goes with one of the intercostal muscles, right? And we're bleeding into the chest. And on the right side, we've got blood and air leaking in for that hemo-pneumo. Traumatic asphyxiation, that chest compression from hell. It forces blood out of the heart at an astonishing pressure, and it typically goes up and out through the vessels off of the aorta, as opposed to down into the legs and whatnot. You can have it there though. So you get a lot of swelling and bruising in the upper chest, the neck, the face, and the eyeballs. Distended neck veins, cardiac tamponade, direct injury to the heart. We get some blood flowing out of it. Again, it's a very tough sac. That rarely leaks. So that pressure builds and the pressure compresses the heart, so it does not beat as well. We do get blood backing up into the jugular veins as a result of tamponade, and we get distended jugular veins. We also get shock. And what we get for blood pressure is what we call a narrowed pulse pressure. So when we get shocky, we expect both numbers to drop basically evenly, right? So 140 over 90, 136 over 90, 130 over 86, right? Both numbers are slowly starting to drop. With tamponade, you get the systolic dropping, and the diastolic will either stay the same or start to climb a little bit. So 130 over 90, 126 over 90, 120 over 90 or 92. Ding, 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 jugular vein distension, narrowing pulse pressures, steering wheel to the chest, cardiac tamponade. Aortic dissection and injury, right? It's the largest vessel. I've already described just a moment ago how blunt trauma can do that, but certainly you can put bullets through the aorta. It is a high pressure vessel, very fast rate of hemorrhage, and primarily fatal. Pain in the chest, belly, or back, signs of shock. You can also, and one of you guys asked me that, I don't know, sometime in the last couple of weeks, about blood pressures on different sides. Great question, and yes, if that, let's say that aneurysm is up in the aorta, up in the aortic arch, and it's partially occluding the vessels to the right side or vessels to the left side, you can get different blood pressures in the arms. If it's down near the iliac crest where the aorta splits off, bifurcates, big word, off into the iliac, left iliac and right iliac arteries, you can have one side or the other be partially occluded. And while we don't check blood pressures in the legs, you can. We have thigh cuffs. You could do that. In 35 years, I've never seen that done though, but you could. But you feel pulses and you get different strengths of the pulse. Now, commotio cordis, uncommon, thank God. Basically, it's a punch to the sternum at just the wrong time in the electrical cycle of the heart, and it causes VFib. So if you remember me drawing on the board at some point in the past, I was showing you the P wave that goes with the atrium contracting. Then I showed you the QRS, which is the ventricles contracting. So I said atrium, ventricles, P wave, QRS, P wave, QRS. Well, there's a little short line, the ST segment, and then there's another hill, shall we say, electrical hill, and that is the heart muscle resting or repolarizing, going back to where it should be electrically. So during that phase in that T wave, if the sternum takes a blow and that blow gets transmitted into the heart muscle, which, I mean, the right atrium where the SA node and the AV node are, sits right behind the sternum. So a blow to the sternum can send an electrical impulse out And depending on how much of the heart is ready for it or not, you might get a coordinated beat out of it, or you might get chaos and VFib out of it, okay? You see or hear about this sometimes with like a 19-year-old basketball player who, you know, takes a headbutt in the chest. He's running down the court, another kid's running down the court, they bang together and he drops, he's in VFib, okay? Abdominal injuries, open or closed. If you rupture one of the vessels in your abdomen, typically it's pretty bad, and typically we're going to get shocky. Organs, the same thing. Now, very painful. Hollow organs give you these peaks and valleys for pain. What do I mean by peak and valley is the pain comes and goes. So at its worst, and it might last for a couple of minutes, it's like a 7 or 8, 9 on a scale of 10. And then it gets a little bit better and it might be a 4 or 5. And that might last for a couple minutes. So, but it comes on and it goes away for a little bit. But a hollow organ that ruptures, like your appendix, for example, very painful, right? It's going to cause pus and blood and fecal matter to leak out into your abdomen, and it's just going to get worse. Now we can have eviscerations, right? Any part of an organ that's sticking out through a wound. And remember, the skin and its parts, including subcutaneous tissue, is considered an organ. So we've got this nice little made up evisceration on this guy. We cut the clothes away. We take a multi-trauma dressing, 10 by 30. We soak it with water, put it over it, and then we put some plastic wrap, whether it be the dressing cover, the plastic dressing cover, over that so that we keep that tissue moist. If that tissue dries out, it can die. And instead of having kind of a nice, easy, well, everything, you know, the surgeon looks at the loop of intestine and goes, well, that's okay, there's no damage to it, I'll just push it back in, I'll sew it up, and we'll keep an eye on him for infection. If it dies, he's going to have to open him up a lot more, and he's going to have to cut a chunk of that bowel out. So now it becomes major abdominal surgery. Now, pain initially may be mild, becomes intolerable, 9 out of 10, 10 out of 10. They can have cramps, they can have nausea, weakness that goes, you know, with being hypovolemic and shocky. Thirst, if you're losing fluid, your body says, I must replace fluid. How do I do that? Well, I'm going to tell my brain I'm thirsty, okay? Do not allow these people to have anything to eat or drink. And then obviously you can have obvious wounds to the abdomen itself. Don't forget to check the back, please. When I do intercepts, a lot of my patients are already secured to the stretcher. They might even be on a scoop or on a board. And I either take the time to undo everything and roll them and look at their back myself, or I trust those folks to have assessed them. I trust very few people anymore because I get a lot of this, right? I mean, if you watch that, you know, do your job video, do your damn job, which means do an assessment. I'll ask people, hey, what the back look like? And they get this really quick, like deer in the headlights look and go, it was okay. That's not what I asked. What did it look like? Okay. And then I know they're just pulling my leg. They didn't do it. So now I've got to undo everything and look, because that hole that you didn't find because you didn't look could kill them. And once I'm in the truck, it's my fault if they die. Okay. It's your fault too, but so please do us all a favor. Look, lift clothes out of the way, cut clothes out of the way. When you roll them, actually look at the skin on their back. Put your hands all over the back. Look for things that aren't right. Okay. Indications of blunt trauma, right? We've got the bruise in the shape of a baseball bat. Developing shock, right? Are they becoming anxious? Are they becoming a little pale? Are they becoming a little sweaty? Is their heart rate climbing a little bit? All developing shock. Coughing up or vomiting blood, ugh, yuck, always bad. Rigid or tender belly, right? You push on the abdomen. If there is, excuse me, a bunch of blood and fluid already in there, besides guarding, it will actually cause the abdominal wall to basically spasm involuntarily, and it becomes hard to push on because the body does not want you to hurt it anymore. Okay, so is it rigid or is it just tender, right? I push, oh, ooh, that's a little sore over there. Or when I push on it, nope, that's fine. And when you let it quick, I go, ow, right? Rebound tenderness. Is it distended? Are they bleeding into the area? If they are lying really still, they don't want you to move them, right? That's moving the peritoneal sac and or blood within it, and that causes pain. Belly issues, they're going to start puking at some point. Put them on their back, let their knees stay flexed, put some pillows under it. If you can, with the mechanism of injury allows, let them lie on their side and curl their knees up in a ball. I like to have them do it on the left side, so they're facing me on the stretcher, right? But that helps take some of the tension off the peritoneum. High flow oxygen, again, this is trauma and care for shock. So you're an intermediate, intermediate. You're an AEMT. These people deserve a couple of big IVs. 18 is a minimum. To me, that's not a big IV. A 16 or a 14 is. You don't necessarily need to start giving them fluid, but you want to have those available so that you can give a fluid bolus if you need to, right? If your baseline blood pressure was 120/80, and your baseline pulse was 72, and your baseline respiratory rate was 12, and you keep checking it and keep checking it, and 20 minutes later, they're all basically the same. And at 25 minutes, instead of the pulse being in the 70s, now it's in the 90s. And nothing else has changed, right? They're not in any more pain. You didn't just start an IV on them, right? Ooh, they're starting to try to compensate. Give them a bolus, all right? 250 to 500. If their heart rate climbs more, their respiratory rate climbs more, their skin color becomes crappy, give them another bolus, okay? Don't just pour fluid into them though. And then transport. So additional steps, control any bleeding that you find that you can. Cover all wounds up. Don't touch these loop of bowel, and don't replace them, okay? Saline onto a dressing and then wrap it. Okay? Don't move any impaled objects either. So stabilize them, put bulky dressings around it, wrap those up, try to keep that thing protected. Whatever position their legs were in when you found them, would be nice to keep them in until they do a scan on this guy, because you move the legs, that may change the position of that knife, and you may actually cut something at that point. All right, so open chest or open belly, something that the skin has been penetrated, and sometimes not just the skin, but you got to think about the muscles underneath it as well. These are life-threatening for either of them, and occlusive dressing over the top. Standard precautions. What's my mechanism of injury? ABCs every 5 minutes on these guys. Non-rebreathers for these folks. Treat for shock and transport. Now, treat for shock. So I just kind of ran you through IVs and some fluid, but for everyone, including me, I mean, as a paramedic, this is even more important than anything else I can do, is if you can keep them flat, right? I mean, if you need to bend the knees up, okay, but I don't want them sitting up on the stretcher. I want them flat. I want gravity to help me perfuse the heart, lungs, and brain. And I want to keep them warm. If you, as a trauma patient, drop your body temperature just a degree or two, your mortality rate climbs. Your need for oxygen climbs significantly. So leave them flat, keep them warm, ventilate them as needed. That's your treatment for shock. Then the A's and the medics and the ER docs and nurses can start to give some fluids a little bit at a time until they can get some blood. So flail chest, we have that paradoxical motion. If they're not breathing adequately for any reason, much less a flail, start to ventilate them with a BVM. Seal anything open, right? In the chest, 3 sides or all 4 sides, but leave a corner, however you want to do that. This Asherman chest seal, I've got some in my truck. When we actually have class again, I'll show it to you. You can also Google it. Monitor them for changes. If you have a pneumothorax, not you, but your patient, right? Well, I guess this works for you too. And you put that seal on it, that 3-sided seal that you made. If they suddenly get short of breath, their oxygen sats drop, their heart rate climbs, their blood pressure drops. I can't breathe, I can't breathe, I can't breathe. It means that they've probably re-occluded that. Either that seal itself may be sticking to the hole. So pull that seal off, have them take a few deep breaths, cough a couple of times, strain to exhale, grunt, whatever they can do to force some of that air back out, and then reseal it. Okay. They take a blow to the sternum, commotio cordis, right? CPR defibrillation. If you have this patient with a closed chest and they took a blow to the chest and you're like, I think they got diminished lung sounds, but vitals are good, airway's good, ventilations are good, this is lovely, and 10 minutes later, I can't breathe, I can't breathe, I can't breathe, and their sats are dropping, etc. They need someone like me to come along and stick a needle in their chest, okay? They need a medic. If you have this patient and you are going to a trauma center, you have to divert at this point, because if you can't put a needle in their chest, they are going to die, okay? Solid organs, life-threatening amounts of blood loss. When hollow organs, they spill everything into the cavity, and these guys get septic really quick, as well as the fact that they're bleeding. Blunt, open, closed, seal wounds, right? So blunt trauma, what did it? How fast was it going? How big was the dude swinging the baseball bat? Whatever it is, okay? Penetrating trauma and compressions. We worry about all those things and what might have been damaged underneath it or behind it. Open or closed relates to the environment outside and the environment inside, right? Is it closed to the outside or is it open to the outside? And seal those holes. Use your mechanism of injury, use your assessment, and look for signs of shock. So that's our chapter 27. And I will see you again shortly in another class, another segment.